Connaissance, recherche, sciences,
mathématiques,
théorie,
physique,
philosophie, conférences, archéologie,
nature.
Good afternoon, everybody. Welcome for this second session, the lecture on experience science and the fight against poverty. So today we're going to be talking about health. Like obviously, we're not going to be talking about health from the same point of view as a bread and butter doctor, even though we might wish to share some medical protocol with grassroots doctors. But from a social perspective, quite obviously, we're not able to talk about the effectiveness of one or other procedure or one particular healthcare line. No, today we're going to be looking at health services and health skills, something that we're not going to be doing today because we don't have much time, not because it's not interesting. Talking about environmental issues from a broad perspective with regard to health. I'm thinking about water, for example, thinking about food issues. We're only going to brush upon that, upon the issues of pollution and things of that ilk. Now, those are very interesting topics, and when you think about health issues, public health issues from a broader perspective, but for problems of time, we don't have to deal with that. We don't have time to deal with that, so we're going to be focusing upon health issues in a more restrictive realm. So, we're going to look at one particular case, a small case, and we're going to focus on the state of Rajasthan in India. Not because it encompasses all the problems of the world. And we might have the opportunity to talk about AIDS. But this study, bearing upon the state of Rajasthan, enables us to look at the procedures and the processes that magnify the issues that are very important to take into consideration. Then we can think about remedies and evaluate those remedies. So, based on that information, we're going to be analysing research and grassroots programs that were decided to espouse solutions bearing upon health issues. Now, a major question is the organisation of the supply of health care. Another recurrent question, and is of interest to us, is social sciences, because once again, we're not able to talk about health care, but we can think about preventative care. There's a huge demand for this and a need for raised awareness of the role of that particular care. It's important to us to understand why that is the case. Why is the request for preventative care such a strong one, and how can we can make this latter more effective? So let's start then, if you will, with this particular case, very specific case. In Udaipur, it's a district in the state of Rajasthan in India. It's one of the most populous and most poor state in India. Now, we were talking to a local NGO that works only in the Udaipur district and in the Seva Mandir area, and deals with education, health and environmental issues in the district of Udaipur. And for the last 7 years, 7 years ago, we were contacted because they weren't necessarily very happy with the way health issues were being dealt with, and they wanted to recast their offering with regard to health care. So, with myself and Abhijit Banjari, my colleague, we were asked basically whether we could recast things with regard to health provision. And it so happens that my colleague, nor I, didn't really know much about health in those days. And so we didn't really feel in the best position to to make any recommendation. So what we did was to launch a one-year study on doing a stock take of health supply and the quests for health provision in that area, and also gauging, appraising the level of health of the people in that area. So we wanted to collate this data for 1 year. We didn't want to rush into the situation. We wanted to have a stock take. Then we wanted to improve upon that data and to put that data at the fingertips of people who are working in health in that area, the government, doctors and NGOs, the stakeholders in the region working on health, and using that to try to draw up various avenues, and then basing a project on those avenues of thought, and then, of course, draw summary conclusions. So all this procedure got up and running in 2002, and is still in the pipeline, still unfolding, because we're still analyzing the latest battery of data. And I'd like to take the opportunity of this lecture on health to track, amongst other things, this procedure, to give you an inkling into what we are involved with when we're dealing with this experimental methods. Let's start with the study proper. So this study began in 2002 and was set to span from 2002 to 2003, based upon 100 villages. And in each village, we chose by random 10 households, so that's 1,000 households, to do in-depth interviews and to appraise the level of health of the given respondents. So we also wished to run an investigation on health services that were at the fingertips of this pollution, the private offering, which is vast, really, because to serve these 1,000 households, 451 doctors, in inverted commas, who are these doctors? I mean, these doctors are people who acknowledge modern medicine, a huge battery, hundreds of doctors who use alternative medicine, and 123 public establishments. So primary healthcare centres that we also included in the scope of our appraisal to do a stock take, but once a week we went there in order to verify the work conducted by employees in these various centres. So this is an example of a deep-seated interview I mentioned earlier on, and also we measure people's height. That's part of the stock take process. So what are the things that have emerged from this study, this year's study? Now, because I don't have much time, I'm going to give you the salient conclusions. Let's talk about the overall state of health of the population, the demand for medical care, and the configuration, the profile, if you will, of the supply of medical care. So let's look at the level of health, low level of health. Some people have dubbed it an ocean of illnesses. So this gives you, if you like, the reported symptoms, percentage of adults reporting symptoms in the preceding month. So either serious or grave. So you can see that 30% of people, of the respondents, complained of cold symptoms. A little over 30% complained of having a temperature or fever. 40%, over 40%, headaches, complained of headaches, etc., etc., and so on and so on. But in a number of these cases, you can see that these symptoms cross-pollinate. So 27 people worried about, will complain of body ache, what they term body ache. In other words, your bones ache, your body aches. And then 30% of people said that they had trouble walking because of pain. So here we're talking about a set of people that is not in good state of health, and that wouldn't be dubbed in medical sphere as enjoying good health. Right, so this is by no means surprising, really, when you try to look at objective health indicators. So we look at, obviously, height and weight. We look at the body mass of a given individual. You know, the weight divided by the height squared. And then we've got a 21, index of 21. That's considered as being, somebody who's not in very good health. 88% of women, 93% of men have a body mass underneath 21, and the average is 18, which means that somebody is really suffering from a bad level of nutrition. Respiratory problems. We could talk and we can measure respiratory problems using an inhaler that people suffering from asthma will be very experienced in using. 360 milliliters per intake of breath was the index there. 56% of women and 51% of men were anemic. If you use a ratio of 11 for women and 13 for men. And this anemic phenomena, more prevalent for women than men, is quite obviously due to nutritional problems. And this problem of nutrition is not specific to Udapur. Something that's very surprising in India, in contemporary India, is the following. Here we've got the number of households that consume less than the recommended 230 calories per person. That's the recommended minimum. This is recommended intake of calories. Now, in 1983, 66% of rural areas were underneath that threshold in terms of their intake of calorie. And in 2004-2005, we'd shut up to 80%. So this is a time when India is becoming richer, and the population is becoming generally richer. The state of health, therefore, is actually deteriorating, which is very preoccupying. And it's, very, very worrying. Other indicators have confirmed this trend, particularly if you look at the height and weight of children over the same period, 1983 to 2002. There's no progress, nutritional progress. And sometimes we've even seen things falling on the back step, things receding and deteriorating. So once again, a population that is not enjoying a good state of health. Now again, it says this is the case as well, this population. In interviews, we talk about all these symptoms and illnesses, and the population, therefore, acts as a consequence. And in Udapur, one of the poorest households spends less than 70 centimes per person. So these are the poorest of the poor, and the fraction of the household budget devoted to health is 7% for the poorest, basically which makes a third of all our sample. 8% rather for the rich, which is between $1 and $2 per household, per spending per household, and then 9%, of course, is the middle between the poor and the rich, in terms of budgetary allocation to health. So we can see, this is a ratio which is high when you compare the ratio spent by rich households in the Western world. So that was a high ratio spent on spending on health, and 7% of GDP in America is spent on health. So you can see the figures. Now, people spend a lot on health, therefore. 7% of their household budget. So they go to see the doctors quite a lot. On average, in our sample, people went to doctors about 1.5 times a month. So somebody in the household has gone to a doctor 1.5 times a month. And who is the doctor? Well, doctor in inverted commas. We'll look at the profile later on. But anyway, go to somebody who's going to provide them with medical care. So who are they going to be seeing then? Well, 20% among the poor of the poor, 20%, and in the primary health centre, which is on their doorstep, or one that's further afield, or even a hospital which is much further afield. So this is public facilities we're dealing here. Now, 51%. We're going to see a private doctor, a doctor in the private sector, and 28% of people are going to go to see the BOPA, which is this traditional offering of health provision in the various communities. So you can see that the private sphere weighs in heavy, which is totally deregulated, and we'll talk about that a little later on. So this private offering really prevails. And contrary to curative care, the preventative care isn't really developed very much at all. An example, we talk about the rate of exhaustive vaccination, so people who've received all vaccinations and are up to date for children underneath 2 years of age was 2%, only 2% when we did our study. The rate of women, the percentage of women who receive medication is also very, very low during their pregnancy, and particularly for mitigating tetanus. Now, curative health care is very much to the fore, and preventative care are pretty much non-existent. So that's the demand, and with those selling features I've just covered. So what about the offering then? So we've got the private sector, which I told you earlier on, which is very vast array of volume of supply. But there's no regulatory efforts on the part of the government, and terrible quality in the current state of affairs anyway. So these are the figures of people that call themselves doctors, which is generally the boss of the community health centre. They dub themselves doctors. So 27% of them are doctors and specialise in a particular sphere. 28% are also doctors. So we've got a little over half, therefore, are fully fledged doctors. The other half are not doctors whatsoever. Indeed, they've got no professional qualifications. 14% of people have received no formal teaching, no formal instruction to be doctors. They've got no university diploma to attest that they're a doctor. There was one, in fact, that we saw who said very seriously that he just finished his secondary school, and when he finished his secondary school, he moved house and set up shop in Auduport and set himself up as a doctor. 21% have got a diploma, but not in 14% rather have diplomas, but not in a medical sphere, and 21% have received an RMP, in other words, a certificate that enables you to give health care, but not a doctor. But I mean, they call themselves doctor, and they present themselves as doctors. So here you've got people, therefore, who are responsible for performing medical acts in a health centre. So this offering can be useful if it's a sorting session, for example. Maybe people go to a pharmacist who then would send them to a hospital or a fully fledged doctor. There would be no problem whatsoever with that. But because these people dub themselves doctor, they behave as such, and so they provide care, and they behave in a rather creative fashion based on the illness. So illness which is very prevalent today in Auduport is the short, well, depending whatever illness you've got. When you go to these health centres, they just throw antibiotics at you, and of course that's not very advantageous for the patient, and actually draws down resistance to antibiotics. So we've got third-generation antibiotics in Auduport at the moment, which are the only ones that are used, but these draw down the individual's resistance. So we've got the private facilities, public facilities, and you can have intravenous with sugar and water in 30% of the case, and injection 12%, and only a test in 2% of cases to test basically to see what you've got. Now, when you go into a public facility, well, you're less likely to have an intravenous injection, only 30%. Less chance of having antibiotic injection, and as much chance of having a test conducted on you, 2%. So that's intravenous injections and the rest. So now let's look at public offering. So we've got a first level, which is a sector centre, primary health provision for 3,000 people. On the paper, That's one centre for 3,000 people, one major, centre for 50,000 people, and then small provincial hospitals or big metropolitan hospitals for bigger populations. So this is a system, if you like, which operates according to a sorting system. So when somebody turns up in the primary care centre, there's a nurse who does what she can or he can, and then sends them to maybe a bigger centre who does what they can, and then basically passes the buck in a domino effect right until we get to the hospital. So that, if you like, that's what happens. Now, it does work to a certain extent. I mean, it works. I mean, at UDEPOR, for example, it's estimated that there is one centre for 3,000 people. That's pretty, bread and butter reality that you see everywhere. They're proximity centres, less than 2 kilometres away from where people live. Well, in UDEPOR anyway. This is true for UDEPOR at least. And generally speaking, there's somebody who is indentured in those particular care centres. In Bangladesh, you have these centres, but they're not staffed. This is not the case for India, because in India there is somebody who's actually appointed to a position and fills that position. So in India, you imagine that the Indian system would work well for a poor country, where it makes it possible to do appropriate sorting in order to send people to the right health structure through the nurse, for example, as I said, and you can access healthcare therefore relatively simply, because it's it's at the most 2 kilometres away from your home. Now, that's okay, also very well on the paper, but in practice, these centres are in a deplorable state. So here's an illustration of this. It's just one room, a desk, and then nothing else. There's no medicine, there's no equipment, medical equipment, etc., etc. Maybe even more serious still, absenteeism rate is even higher than for teachers. The average absenteeism for nurses is 54%. 54% in UDEPOR. When the centre is supposed to be open, it's not going to be open because of absenteeism. And 54% of rate of absenteeism. When they turn up to these centres, well, this gives you an idea of the backdrop. On UDEPOR, it's a very dry climate. You have to walk a bit. It takes about half an hour to get to that particular spot.
But this is not specific to UDEPOR. In the very same survey in which investigators visited schools to see if teachers were present or not, they did the same in the health centres, and they realised that in all the cases, in all the villages they visited, the absenteeism rate was 54%, and even slightly higher for nurses than for teachers. In terms of treatment now, as we said, treatments are better quality because there is less antibiotics or infusion, but there are not more tests anyway. And if you look at on paper at what these nurses have to do, it's such a large range of tasks that it's just impossible for them to do everything at the same time. And that has 2 consequences. One, the number of tasks ends up in their mission not being very clear and is damageable for their credibility. One very clear example of that, and which is something very serious as well, is that nurses are, amongst other things, are in charge of making women accept to get sterilised because controlling population growth is top priority for the healthcare system. So these nurses are in charge of convincing women to get sterilised, and they get sanctioned if they don't get enough cases, what they call cases. And obviously the population don't want to be sterilised, so they spend a lot of time in the villages trying to persuade women to get sterilised, and as a result the population is very suspicious of the healthcare they could provide because people are afraid they might get sterilised without even knowing it. So, of course, this also is rooted in history, because in the government of late Mrs. Gandhi, there were special hospitals to which women were taken and were sterilized by force, so to speak. So this could also be the case today. So that damages their credibility, and that makes their other roles, like, for instance, encouraging parents to provide vaccination to their children, very difficult. The second consequence of these multiple tasks they have to do is that they have so many things to do that they don't even try to achieve any, because they can always tell Mr. A that they were doing what Mr. B told them to do. And as there is not much monitoring or control, that ends up to absenteeism, and many of them would just stay at home. Hence, I mean, we've seen that with teachers last week. If you ask people to do the impossible, then they don't know what they have to do. And that has an impact on what they do or don't do. So that's so much for the public sector. The consequences now, as you have a private sector, as I explained, and public sector, like I just explained as well, all this has consequences on demand. But the structure of demand also has a consequence on the structure of supply. So it's kind of a loop here. What we see with data is that in those villages in which the nurse is absent from the health centers, or health centers where people don't go to, and therefore they would go and see traditional doctors for the poorest and private practices for the richest. So when the nurse is not in the center, people don't go to the health center. Two possible explanations to that. Either they're discouraged waiting for the nurse, or nurses are discouraged because nobody comes to see them, and for them sitting a whole day in a room like I just showed you, for someone who's studied for quite a long number of years, because in India nurse studies for quite a long number of years, and sitting there in this small room with no electricity, nobody coming, that's not very encouraging. So it's because of lack of patient that nurses don't come to the health centers anymore. These are two explanations that can both be true. This is something we can't deny. So in order to try and understand the situation and try and improve it afterwards, the first answer would consist in saying, okay, let's improve the offering and see what the impact is on demand. And that's the response of Indian authorities today. At national level, the way to cope with this situation consists in putting more money in the system. So within the framework of the rural health care mission that was decreed by the new government because of the very poor quality of health and education services, the budget of health is going to increase, moving from less than 1% of the GDP to 2% of the GDP. So they put more money, but more money in exactly the same system. So if I sent you a new picture of the local healthcare centers in a year's time, they'll be exactly the same. Now, at local level, at district level, there is one person at district level that corresponds to what a French prefect is. So that's the state representative at district level. And in the discussions we had after we carried out the survey, we described our findings, and the response of this prefect was, okay, fine. So we'll make sure that nurses are present in the local health centers at least one day a week. That seems to be a reasonable objective, but that means that they are not to attend any meetings, they're not to carry out any visits in the field, and every Monday, for instance, nurses have to be in their local center, and we'll check, and if they're not, they'll be sanctioned. Okay, so having made that decision, the local prefect decided to work with the NGO we were working with to try and test a follow-up system to make sure that actually nurses were present in the field on a weekly basis. So they selected 33 local health centers, which is selected at random within the district. So they distributed stamps to the nurses so that the nurses would stamp the logbooks when they walked in and walked out. And then the government, local government, would control these logbooks. And the prefect announced sanctions for those nurses who were absent, too often absent, like more than half of the time. So the system was launched. And as the pilot system was only implemented in 33 centres, because that was a test system, a team, including researchers from the local university, went to visit these centres on the Monday, along with visiting other centres where the pilot system had not been implemented, to try and see if this monitoring system, top-down monitoring system, was inefficient, because it was a top-down system. It was decided by the prefect and imposed on the nurses. So here are the results, and let's start with the left of the graph. Here you have the percentage of nurses present. So that's at the very beginning of the experiment. This is the percentage for nurses present on Monday. At the beginning of the experiment, those centres in which the system was implemented have a much higher rate of presence than in those centres where the pilot test was not implemented. And that's on the Monday, because you see that there is very small difference for the other days. So they've understood they need to be there on the Monday, and they're present on the Monday. But after 6 months, so that's the first 6 months, and after 6 months, we can see there is a decrease in their presence, even in the group which is being followed up, but there is an increase in the other group. Don't forget that the obligation to be present on the Monday was valid everywhere. It's only 33 centres that were carefully monitored, but the obligation was true for all centres. So we see here an increase, and in the end, the two graphs come back to an equal situation. So you see here that in the first 6 months, we have a sharp increase in the rate of presence, and then this impact wears off, so to speak. So the results is that at the beginning, it has a major impact. Nurses are very sensitive to the program, but that wears off. So what happened? Well, the key is in the logbooks that were kept by the nurses. What do we read in these logbooks? Well, in blue, they're present at least half of the day. In white, they're absent. And in red, either they're excused or the machine has a problem. See that at the beginning, they were very much present, very few people excused, and you see that the level of official absentees remains equivalent. And when the number of days of presence decreases, it's largely compensated by the number of people excused or machine problem days. Because when the machine has a problem, it's counted as an absence, even if, except if the nurse was present to sort out the problem. But look at the days with an excuse for the nurse. Well, the nurse can claim that she was to attend a meeting. So she writes down in the logbook that she was attending a meeting, although, remember, they were not supposed to attend any meetings on the Mondays. So we checked, because there is a list of meetings at district level, so we could check. We checked that there was no meeting organized on the Monday, but they wrote meeting, and their immediate supervisor accepted the excuse. And the immediate supervisors of the nurses are increasingly accepting excuses, nursing making excuses not to come. So they have this kind of implicit or even explicit agreement with their supervisors to be which allows them to be absent. And this is why the system that's worked well at the beginning stopped working. So these results are in sharp contrast with those which have also been obtained in Udaipur and with the same NGO, but for teachers, where absenteeism had moved from 40 to 20%. So that shows clearly how difficult it is to cut and paste the results of one experience and paste them on another. In our case, it's the government and the supervisors who need to sanction the absence. In our case here, the healthcare staff, doctors, supervisors, had never really gotten involved in the system despite the pressure put upon them by the prefect. It's the prefect who wanted to introduce a system, but he never had any buy-in from the doctors. So now, what can we say about the differences between the two groups, the one that was monitored and the other one? Well, nurses, as they're asked to do so many things, they always try and understand what's really important in what they're asked to do. And if they look at the logbooks and the reports, and if they see that despite they were absent on a Monday, they're never sanctioned, then they realize that this obligation is not a genuine obligation. Whereas in the centers where they were never controlled, they never learned that it wasn't a real obligation. And they never learned that their presence was not all that important. And this is something that they explain, because you need to talk to nurses. These are very straightforward people. And they said to us, the only thing that matters is sterilization of women. This is something that we've realized, and now we're not making any efforts to do anything else. So that's the one explanation why this program shifted from relative success to total failure. Now the question is, why didn't the government stick to the rules that they had written themselves? One possible answer is that there is probably no genuine political will behind that. And the population never came back to prefect and say, well, you told us there would be somebody in the center every Monday, and there is no one, and they never put pressure on the government. One symptom is that even during the 6-month period when the nurses in the test group was higher, the number of patients visiting the health center was very low. If you walk in the center on a Monday and you look at who is there, there is less than one patient waiting in the waiting room, and usually there is no patient at all. On average, it's less than one person. And in those centers that were being monitored, the figure is slightly higher, but still it's less than one patient. So it's possible that a top-down system like this one that was imposed by the prefect with no buy-in from the bases can not really survive. And one example of this, one thing that could lead us to saying that this is probably the case, is another experiment that was carried out in Uganda. Instead of selecting a top-down approach, they chose a bottom-up approach within the context of the Power to the People program. And the objective of this project was to use the mobilization of users. Whereas in the system in India, they were using the role of the hierarchy. But there they decided they would start from the field, from the citizens. In Uganda, even if the context is different, the problems are very similar, and the rate of absenteeism in the healthcare centres was around 47%, so similar type of problems. But there, what happened is that a series of NGOs and very local NGOs, what we call community organizations, well, a series of NGOs decided to work together and do as follows. They carried out a major survey with the households and asked them what their experience was with the healthcare system. Then they organized meetings at village level to share these results. So 3 meetings out of 2 days, 2 days in each village, working with the villagers, 1 meeting in the healthcare centre to work with the medical staff to get their perspective and talk about the results of the survey that was carried out with the users. And then there was a meeting bringing together all these people, the users and the medical staff, with the objective of implementing an action plan in order to improve quality, and it was also an opportunity to members in the community to do their job and make sure that people were coming to the health centre, were really giving vitamin to the kids, etc., etc. So it was a jointly agreed action plan to try and improve the situation. So this program gave pretty good results. One, the community got far more involved in supervising the medical staff. So people who were present were replaced by people who were more committed. People spent time in the health centres to monitor what was being done. The medical staff was more present. The absence rate has gone down from 47% to 34%. The use increases, i.e. the number of patients increases from 661 visits per month to 791 per month in the tested groups. So it's more used. They did not stop using other treatment methods. 36% 36 or 35% people still use self-medication or resort to traditional healers. But where we see the most dramatic impact is on the mortality rate for children under the age of 5, which dropped from 144 per thousand to 94 per 1,000. So, and this is comparing communities where the program was implemented versus communities where the program was not implemented as usual. So after a year, they carried out another survey, and they saw that the results are still there.
So the conclusion of this contrast, if you like, between these two experiments, the top-down, bottom-up contrast, is the following. Well, it would seem that a top-down approach, without mustering the local communities and without increasing demand, isn't successful over the long term, but a bottom-up approach, without any involvement really from the authorities, even though they look at the situation in a benevolent fashion, that actually provides more long-term probant findings, which means it's possible maybe to trigger a cycle of supply and demand, a virtuous cycle, which makes it possible in the long run to improve the health set of circumstances in a more sustainable fashion. Now, all that leads us to the following. Well, the next stage in my reasoning, that the demand for public health care provision of a quality level is crucial to any reform in public service provision. So without any support of demand, approaches will go into the wall. So why is demand so low? Why, with the public health centres in Udaipur, why didn't people start turning up when they were told that the nurse would be there longer, and indeed she was there longer, and particularly over the first 6 months. Well, why? Well, because users aren't gullible, because the reform probably wasn't going to last in their minds, and it didn't last in their minds. And they don't think really that any change is going to be enduring, so there's no reason for them to change their behaviour. The second, well, in that case, of course, if it was possible, if a Deus Ex Machina could parachute a durable, sustainable system, then you would see probably people actually turning up on a regular basis. Another possibility, which is a bit more preoccupying, but needs to be taken seriously, is that the underlying demand for healthcare provided in public sector centres is low, but in private facilities it's higher. Now, in private facilities you can go there with any illness, and you're going to receive an antibiotic injection. You go back home, and nobody's asking you anything, nobody's going to bother you, nobody's going to ask you, nobody's just going to sterilise you or harm your children. But in public authorities, it's more preventative care. And nurses aren't accredited to be able to give antibiotic medicine, even though they do so sometimes. So there's a different set of circumstances. And here we're dealing with a supply of healthcare, which isn't of necessarily of interest to people. Now, we have to delve into that. And when we delved into that in a bit more detail, we saw that there was a genuine increase of offering when we think about alternative medicine. So we actually observed that. Now, we can be talking. This organisation works for the last 5 years in the region, and alternative medicine provision I'm talking about, and enjoys a good reputation with the local communities. Local communities think that these healers take them seriously, and they realise that they feel that their illness is going to improve. So there is no crisis of confidence, if you like, between local communities and these healers. So if you remember, vaccination rates are very low, which to all stakeholders, when we talked about the issue, we thought that was one of the crucial problems. And also, it was morally unacceptable in our minds that only 2% of children were fully inoculated, whereas vaccination, of course, is freely available and free. And, of course, that saves lives at the end of the day. So, if you like, there was a volition on the part of the government and the grassroots stakeholders to try and pull the stops out and do something tangible to improve the situation. So another agreement was made between the various stakeholders, between the government and the health centres, in order to implement a vaccination campaign which would take the following shape: to offer free vaccinations in these health areas, health centres, and get a motorised nurse to go into the villages and to offer on the first or the second or third day in the month a wave of vaccination for all children in the villages. And this was well publicised in advance by a health promoter, if you like, a health advertiser, if you like, who announced to the families what was going to happen on the first, second or third of the month. So this vaccination session did take place very regularly on a monthly basis. They walked the talk, so all the sessions took place, or almost all of them, except when it was raining. When there was a monsoon, for example. Anyway, they were well publicised, so people were fully aware that they were going to take place. So, with that in mind, it's like the vaccination. Well, these vaccinations took place in 60 villages, chosen at random among the 120 when we rolled out the initial study, if you remember. Now, I'm going to focus my remarks upon 30 villages and compare them with another 60 villages where the vaccination program didn't take place. So you can see that there is incremental improvement. So 17% of children completely vaccinated aged between 1 and 3. So they receive all the necessary vaccinations to combat measles, polio and other child diseases. We've switched from 6% to 17%. That's not too bad, is it, by way of results? But what's also interesting, to my mind at least, is that here we've got significant progress. 50% to 77% improvement in the number of children who've actually received some vaccinations. But over the vaccination period, you lose more and more numbers of children benefiting from the vaccinations. So you can bring them once, but as time goes by, they don't return for an exhaustive amount of vaccination. So 88% of kids, sorry, 83% says the speaker, 83% of children weren't fully vaccinated despite the very low cost for households, because all they have to do is go to the actual village where the campaign is taking place. Now, the results in Uganda for vaccinations were the same. In other words, people went to the first vaccination for their kids, but they didn't return necessarily. Now, almost all children receive BCG, but all the other vaccinations, much less. Now, this example, well, even though vaccination is available, widely available, and people know that, these vaccinations find it difficult to sustain over the long term. The vaccination is not the only example where the cost is not the only barrier, if you like, the only impediment to the implementation of a preventative care program. For example, breastfeeding. What's recommended by the WHO is to provide breastfeeding for 6 months for children, particularly where water is a particular health risk. In India, a quarter only of women breastfed their kids in the year following the birth. Even though that the WHO recommends to start breastfeeding in the hour that follows the birth, and that for a minimum period of 6 months. So let's go back to vaccination. So for the number of the children receiving treatment against intestinal parasites, start in the first year there was 78%, and that dropped to 59% when the parents had to sign a form. That's the only thing. There's no extra cost. All the parents had to do was sign a form. So that was implemented, and you can see that the number of children who received care dropped from 78% to 59%. Now, to explain that low demand, what can we say? Well, one avenue of thought is that some people are frightened. People are frightened of vaccination because they think that there'll be something there that's nefarious for the child. They're frightened. The parents are frightened. They might think that this is a concealed way of sterilizing them in a coercive fashion. But over and beyond that, we can see that in a whole battery of studies, there's a huge elasticity, a high elasticity of price, both when the prices go up and down. In other words, if you give something free in the first instance, and then you get somebody to pay for it, even small sum for the second usage, then that really discourages people significantly. So in the first year, let's say, it's free healthcare. In the middle, we've got between these two administrations, we've got well, here you've got to sign the form, if you remember. So free first, then you have to sign the form, and then 30 centimes for receiving the medicine. So you drop from 77% to 20%. So basically, and that's from moving from 0 cost to 30 centimes cost. So second example, mosquito nets. We talked about that in my inaugural lecture, giving a mosquito net to the tune of $5. Well, it costs $5, but you give it free in the first instance in order to stop somebody contracting malaria. And it's particularly true for pregnant women. It's during pregnancy that you need to combat malaria. And so in the primary centres, health centres, women were receiving those free mosquito nets. So 61% of people receive these mosquito nets when it's free, and they use them. 41% used them when they had to pay for their mosquito nets to the tune of 10 cents. 20% used it when the price went up to 50 cents. So water purification as well is interesting here as well, because you've got three goods then, different backdrops. Now these examples taken from Kenya with a certain range here, pretty similar range, as you saw with the two previous examples, and starting from high levels. So you've got, by raising the price even slightly, you're actually really drawing down the number of people who are going to benefit from this. So we go from zero to paying for something really means that people, there are vast less number of beneficiaries. When you go from zero to a negative price, in other words, you're prompting somebody to come, so not only are they getting something free, but they're also giving a sweetener to come, then a huge number of people come back. This is true for vaccinations. Remember, we're 60 villages where this vaccination campaign was conducted on a monthly basis. Now, half of these villages, they were given 1 kilo of lentils in addition to the free vaccination, and they would receive something else if they would continue right throughout the course of the vaccinations. Now, 1 kilo of lentils is quite significant. Now, a lentil is a basic foodstuff, but 1 kilo corresponds to, let's say, one day's food for a household of 5, and it corresponds to 1 or 2 rupees. So it's not a major carrot, if you like, but it is a prompt. And that said, you can see that even with those kilo of lentils, there's a significant increase. You remember, with the infrastructure that we implemented, 1 kilo of lentils will take you from 17% to 38% for a complete, exhaustive range of vaccinations. And then vaccinations, and you can see that after the first and second vaccination, this is true as well, where in places where there isn't lentils, if you like, 1 kilo of lentils, people become dispirited and don't return. But when there are lentils, a greater instance of people actually return. No, some people didn't wish to go right to the end of the course of treatment, but others did, because there was also this kilo of lentils. Another context, which is very interesting, is that giving lentils brings other people in. People are ready to walk half a day to get those lentils that they would be able to pay for otherwise in a half a day's work. So 6% in the control village, 70% where the campaign was implemented, 38% when was the lentils as well, and in a 10-kilometer radius, you're also bringing in 10% extra. So a small prompt, if you like, really changes radically people's behavior. Another example for you, perhaps even more surprising. This is a study done in Malawi on a case-by-case basis, done by Rebecca Thornton, and by voluntary tracking of AIDS. Now, voluntary tracking is considered in a number of countries, in particularly countries that are meeting with a lot of success in combating AIDS. I'm thinking of Uganda in this respect, and this is one of the cornerstones of the fight against AIDS. It's 55% of all the AIDS budget, prevention and treatment, all rolled into one, goes to encourage voluntary tracking. But despite that, few people have actually had a test and don't know whether they have AIDS or not. So what we can see is that the psychological barrier and social stigma to know whether you've got AIDS or not is very high, is very marking. People in the short or medium term, this is true. And, of course, there's a social stigma. Even to go and get a test, that means that you may have AIDS. And, somebody can point the finger and say, well, he might have AIDS, and that's social stigma. So these barriers, these impediments are quite high. So we wanted to test that. And Rebecca Thornton implemented the following test to do so. Now, she worked in conjunction with a team of researchers that in the scope of a broad-based study focusing on the health status of people in Malawi, the state of health of people in Malawi, rather, they did anonymous AIDS tests on 2,812 respondents. And a few weeks later, people who actually had provided input in the test had the opportunity, if they wished, to come and get their results. So that was, if you like, what was provided for in the aegis of this experiment. So they do the test, No, they're asked, well, do you want to be tested? Do you want to receive a test? If you accept to have the test, well, we'll do the test on you. And then if they wish, then they can come and get the results. So that was, that's the only way that they would get the results. General people accept to be tested if you don't tell them the result, actually. But here it was, okay, you're going to be tested if you wish. And then if you wish, again, you can come back and find your test. Find the results of your test, and then you can benefit from all the ancillary advice that generally occurs before you actually receive your test, your test results. Now, Rebecca also implemented a certain amount of randomization. The first wave of randomization was the following: that after the interview, an individual can pick out a bottle. Could pick out a prompt, if you like, out of a bag, if he were to go to collect results. And this could go up to, I don't know, a nice carrot up to, say, from 10 cents to $3. And then the second thing, in order to measure the social impact, Rebecca Thornton, on a randomized basis, decides where to place the tent. Sometimes it was planted in front of the tent. The tent was planted in front of the village, so people could come to get the results either outside of the vicinity of the village, so they had to walk, but that was more private, and so everybody wouldn't be pointing their finger at them, etc., etc. So either it is close or in the vicinity of the village, as here, as you can see in this picture here. Here it's in the previous picture rather, and this one it's very close to houses. So now, if you come to get your if you come to get your test, it's very close to your village, and so everybody therefore can see you. So you can see that social stigma might enter into the fray here, but of course this was something that Rebecca Thornton wished to test. So the findings are the following. First and foremost, people are more likely to go and get their results when they're given even the smallest of prompt. It goes from 32% of people who are going to get their results without a prompt to 65% who do receive a carrot. So that slight carrot really shakes people up. Now, the others, there's not too much of a significant difference. If you go from 50 centimes to $3, it's not the money that's prompting. It's just the prompt in and of itself. Now, second, with regard to distance, the tent, how far it was away from the village. So generally speaking, if the health centre is farther afield, people are less likely to go and get the results. So the question of social stigma is not necessarily playing into the equation here, but you can hear then that obviously the prompt, as borne out by this graph, is still very, very important. What do we learn, therefore, from this? Well, this is very interesting. It's very interesting, this price sensitivity, in both examples that I've cited. In both examples, price sensitivity of the demand for preventive care is very interesting. It's very surprising, because generally speaking, you think that the benefits of knowing benefit of vaccinating your children or knowing in Malawi whether you've got AIDS or not. Because in Malawi it's interesting because the antiretroviral treatment is available in Malawi. So this can really change your lot. And and if you don't have AIDS, then you can actually take steps to try and make sure that you don't contract AIDS in the future. So with these small levels of investment, vaccinating kids or going to get your test, when it's just from near to your village, you would imagine that demand would be high. So why is demand not high? Well, it could be because either people are frightened, for example, or lack of trust, or psychological fear. In other words, this is why maybe people are turning away from having their AIDS test because they're frightened. Well, if that was the case, then even small prompts would have no effect, because obviously if you're really frightened of having your kids vaccinated because you think that might be a camouflage way of sterilizing them, well, it's not a little tiny carrot that's going to make you vaccinate your kids. So it's very difficult to understand this huge price sensitivity, this huge sensitivity from a mainstream perspective. So this brings us to our next question: why is preventive care price sensitivity so high based on small variations of price, such as we've seen?